Thanks for coming back to my channel. I just wanted to make a quick video about some things that I picked up along the way on how to deal with difficult patients. So I thought this was a really good time to do that since, with the hospitals and patients and the pandemic going around, that a lot of people are stressed, especially if you have to be in the hospital. So for my first tip is start the report as soon as you walk in the room. Like for me, when I would walk in the room, I'd tell my patient, how are you doing today? And I'll probably say, well, I probably should add something else, right? Because if you're here, it's not a great day. I'll have to come up with a better punchline. And they'll either say, yeah, you do, or hi, or, oh, I'm just, and then they'll proceed to go into what brought them in today. But it kind of is like an icebreaker right off the top. So that's one thing that helps me, actually helps me prevent dealing with a difficult patient. Because when they come in and you just straight start going to, I'm finna take your blood, I'm finna do this, I'm finna do that, they kind of just, I guess, put up this defense. And they feel like you're just finna task and you're not even gonna listen to them. Now, I am a nurse, so I do understand the need of when you need to get in, get what you need to get in, get out, because you might have sick, multiple really high acuity patients that are really sick, and your mind might not be in the kind of chit chat mode. You just kind of really focused on getting the care done and complete. So, I mean, there's times when you go through this, and there's times where it's appropriate to still address your patients and build a rapport with them, because it's going to help you in the long run. My second thing, well, I didn't think I was going to number them, but I guess I'll jump on the numbering bandwagon right now. So the second one I would say is when you have to do an IB. A lot of patients become difficult when they feel like they're going to have this tug of war with IBs. They don't like them, or they are a hard stick and they're used to being poked multiple times and they just get annoyed. So with me, when I'm looking for an IV, I sit down at eye level with them and I kind of start talking. I'll either start talking about their symptoms, or it's so hard because I can't script you on how to talk to patients. It's kind of mixed in with your personality, but I'd say, if it's a man, who's this beautiful lady here with you? And he'll either say my wife, my daughter, or whoever. And also that kind of lets you know who's in the room. Or I'd say if they have on something unique, or like a weird hat or something, or if they already being difficult, or just kind of like, you can tell the family nudged them in. I'd be like, so, should I take your shoes? Because you look like a runner to me, and then they'll laugh and, haha, kiki. And then we'll go about our business while I'm looking for this IV. And a little tip for that is listen to your patients. If they tell you that there's a vein that blows all the time, or they never get it, 9 out of 10, they've been stuck there a lot of times. And, everybody probably tells them, oh, I'm going to get it because this is a great vein. I hardly ever get the veins that they tell me. For some reason, they don't have a good job getting them. And sometimes I do, you know what I'm saying, to my own horn, you have your good days. But I say listen to them. 9 out of 10, they know where to go, especially if they're a hard stick. Now, I will do a compromise. If I see a better vein and they're insisting somewhere else, then I'll say, listen, if we don't get where you want to go, then I'll have to poke you a second time. Are you okay with that? And then 9 out of 10, they'll be like, okay. And then I'll get it where they told me to go. And if I don't, then they are okay with me going where I wanted to go. So now the exclusion to that is if a patient, vital signs are crazy, you're anticipating like a CTA or anything that requires a large bore IV, you have to get what you can get. And I let them know that. I say, listen, I'm anticipating if we have to do this scan, then this IV needs to be here, and it needs to be, able to withstand the pressure of the contrast. And they normally like, okay, because I'm saying if we go in your hand or something like that and they order this test, then I'm gonna have to come in and put a second IV in, you know, and you might end up having delayed care if I can't get in at that moment. And I mean, it's just like communication, and it normally works out for me. And if it's not working out, then that patient is just one of those difficult patients that nothing, you know, is going to satisfy them, and it's their way or no way. And at the end of the day, then it can be no way because it's their body and they can go. But we're going to keep this moving on a positive note. The next one is try to anticipate their needs so you're not coming in and out the room, which will make you frustrated, in turn will frustrate them. So before I leave out, I ask about blankets. I let them know up front that no water or food until all their tests come back and the doctors are able to evaluate. As you get used to working in the ER, then you'll kind of anticipate and know how things go, and you'll know if it's something that they don't need to be NPO for. But a good general rule of thumb is nothing by mouth until all their lab work come back. And because that makes people cranky, you know, if they're already hungry and they're going to be there for a couple of hours waiting on lab work, they get hangry. But I let them know up front. The more you let them know up front, sometimes the easier the process can be. So the next thing I would say is give them their light. Give them the call light. Don't forget to do that, because they get even irritated if they have to try to figure out how to unhook themselves from everything, or they can't unhook themselves and they have to go to the restroom. That will piss somebody. It'll piss me off. So if for no other reason, that light is important for when they need to go to the restroom. And sometimes it turns into like one of those little bells that people ring. Oh, I need this, I need that, I need that. And if somebody's on the call light too much, then I'll go in there and be like, what do you need before I leave out this room? You know? And I just put it to them like that. So I feel like when you're genuine and you mix it, like when you have to be stern or you have to give them answers that they don't like, they're kind of understanding, because you've established that you care about their care, you want them to get better, and you want to do what's in their best interest, and you listen to them. So that's why I say it's important to have a genuine connection. Let them know if you're going to be gone. So if I think, like, if I get an EMS or we get an EMS report that we have something coming in that sounds like a train wreck, I'll try to go into my patient's room, check on them, let them know I have a really sick patient coming in. I might not be in for about an hour, hour and a half, but you have your call light if you need immediate attention. If not, then I will be back in to check on you as soon as I get out of that room. So then when I do come in about an hour, 2 hours later, then they understand it wasn't a shock, or they just haven't heard from me. So that normally helps me out a lot. And, you know, some nurses, you know, so this works with your personality, and you have to tailor this to your personality. There's some nurses that's not going to go and do all that, or, you know, they don't feel the need to explain their whereabouts and every move that they're going to make. And to each his own. I'm just saying this is what's worked for me so far. Not knocking anybody else. Update your patients. Let them know what they're waiting on. So if I come in, and sometimes we'll get the blood work, and then 35 minutes later, then they get to CT. And so now they're waiting on the blood work, and they're thinking that the CT results are going to come back fast. So if I come back in the room, I'll tell them, oh, some of your blood work's come in. We're just waiting on that CT to be read. And once that's read, it'll let the doctor know that it's read, and he'll look over it. But he will come back in and talk to you if there's a critical lab that needs an immediate intervention, or when everything's back, and he'll come in and update you on your plan of care. So I let them know what they're waiting on, how this is going to go, so that they have an idea. A lot of times patients will get irritated if they don't know, you know, kind of what they're waiting on or how this is going to go. So I kind of try to give them time frames. And your supervisor, and they have whole boards dedicated to this process. A lot of times I don't have time right on the board. I'm just going to put that out there. You should write on the board. It's good practice for the hospital. But I don't be writing on that board all the time. But at least I told them. Next thing, I have them address their pain with the doctor at the bedside. I do not like if they ask me after the doctor just left that they want pain medicine or they're in pain, because that just delays it. I have to go ask him, and then if he's not, especially those ones who have their requests, they get angry when you come back and say no, which is okay because that's what end up happening a lot of the times. But I love to remind them before I leave out the room, if the doctor hasn't been in yet, do not forget to address your pain with him. That way he can let them know yay or nay if he's going to give them what they want. And especially with the opioid crisis, they are trying a lot of drugs that don't give you those same side effects. And patients aren't always receptive to that. So they can explain it and let them know. And they know from the doctor's mouth that they're not getting Dilaudid or they're not getting morphine. If not, then I just have to go ask them and then let them know. And a lot of times I'll tell them, he's not going to give you that. We're going to try this and see how that works when I reevaluate you, and then we'll go from there, and I'll let him know, okay? And they might not like the answer, but I let them know I don't write orders. That's how I let the doctor know about their pain. He says, we're going to do Tylenol. This is what I have for you. Next, just make that connection with your patients. There's no next. That was the end of the tips. And it's so hard to do this because I understand the patient point of view and I understand the nurse's point of view. That's the troubles of being a psych nurse. I was a psych nurse before I was an ER nurse, and I've always been a really empathic person. So I feel people's vibes and their energy, and I move accordingly. So I will end it with a story time. So I had I had to leave my shift to go get my mother, who wasn't feeling well. Turns out she needed a blood transfusion, having a mild heart attack and other things. So I had to sit, and I brought her back to the hospital I worked at. And so I had to sit in that room for like 6 hours waiting for things to come back. So again, I feel like, so I'm religious. So I feel like God always keeps me humble, keeps me in the perspective of my patients at times, So it was fresh how it feels to be sitting in a room waiting on things, especially when you're worried. She ended up needing like a blood transfusion and everything. So after she got a room and got squared away, I took upstairs and my sister came and sat with her, and I had 2 hours of my shift left and it was busy. So for one of the nurses, I offered to take one of her patients up, and she was like, thank you so much. He's been waiting for a long time to go up and he's pretty irritated. So I walked in the room, and as soon as I got in there, he was just like, oh, finally. And I'm like, what? He's like, finally. Am I going up to my room? Because if I would have known I was going to sit in this ER all day, I wouldn't have came. So at this point, I'm like, I came back down here to help, and this is what I walk in on. So I wanted to react, and I was just like, well, I'm sorry that you had to wait, and it still would be quite a bit of a wait, but I'm here extra, so I'm going to go ahead and take you up to your room and get you settled. And I mean, he just continued to kind of just mumble stuff, and his wife looked a little bit embarrassed, but she was irritated too. So I, was getting all his stuff together, and I think I said something, or he just was like, I mean, this is ridiculous sitting in the ER this long. And I was just like, well, no, I can totally understand, because I just sat in this ER for 6 hours with my mother, waiting for test results and stuff to come back to find out she was having a mild heart attack and needed a blood transfusion. And the reason why I'm free now is because I just took her upstairs to her room and got her situated, and I thought I'd come back for the last 2 hours and kind of help. So then he kind of looks and he was like, I'm really sorry to hear that about your mom. And I was just said, no, I just kind of, I said, I know what you're going, I know how that feels to sit in these rooms. It's fresh on my mind. And he kind of laughed, and he was like, I just got out the hospital yesterday. from having being in here for almost a whole month. He said, I just had a kidney transplant and I woke up this morning coughing up blood. So that kind of put me back into perspective. I'm like, I'm so sorry that you had to be back here, but we're going to take care of you and we're going to get you feeling better. And congratulations on the kidney, by the way. I'm happy for you that you got one. And he was like, yeah, I'm so happy too. And then, we just kind of had some chit chat on the way that I took him back up to his room. And then even when I was taking him to his room, he was in the back of that hall. And I was like, oh, so they putting baby in the corner? I said, don't whip out the stereos or anything. And he just started laughing, and his wife started laughing. He was like, hey, I'm sorry, I was rude. First, he was like, I was just tired. And I was like, I totally understand. But, I'm going to pray for you, and I hope that's not offensive to you. And he was like, no, I can use all the prayers I can get. And we left it at that. So my thing is, I said that to say, and I gave that story because as a nurse, I was frustrated. And a lot of times nurses are tired and you're overworked and you're frustrated and you just don't want to feel like somebody's punching bag. And then on the flip side of that, this might be the worst day of someone's life. It's kind of hard because we get a lot of frequent flyers. We get a lot of people that come in for non-emergent situations and are really mean and assholes and expect us to be their punching bags. So sometimes instead of filtering out those patients, some nurses shut down and they just have this business-like, business-like approach. Get in, get out, do what I need to do. And those are still some of the best nurses. I've met some nurses like that, and the patient might be an asshole to them and thinking that they're not doing anything, and they'll be their biggest advocate when it comes to the doctors. Like, no joke. So these are just some things that have helped me. I hope they can help you. If they do, let me know. If you like videos like this, I will try to make some more. So until then, have a good day. Take care of people and take care of yourself.